Welcome to another episode of Med Madness. Today we delve into an essential topic for medical students and practitioners alike, the management of preterm pre-labor rupture of membranes, or PPROM. Understanding PPROM is crucial as it poses significant risks to both the mother and the fetus. In this episode we will define PPROM, discuss its causes and risk factors, examine its pathophysiology, explore the symptoms and clinical presentation, review diagnostic methods, and discuss management and treatment options. We will also present a real-world case study to illustrate these points, and finally, summarize the key takeaways. Next, let's discuss what this condition is. Preterm pre-labor rupture of membranes, or PPROM, occurs when the amniotic sac ruptures before labor begins and before 37 weeks of gestation. This condition is critical to recognize due to its potential complications for both mother and baby. Common causes and risk factors for PPROM include multiple gestations, prior preterm delivery, a history of PPROM, genital tract infections such as bacterial vaginosis, and antepartum bleeding. The pathophysiology involves the weakening of the fetal membranes, often due to an underlying infection or inflammatory process, leading to premature rupture. Patients with PPROM typically present with a sudden gush or a steady leakage of fluid from the vagina, which is confirmed to be amniotic fluid. This condition can be identified through the pooling of nitrazine-positive fluid in the vagina, with accompanying signs such as a closed cervix prior to labor onset. Additional symptoms may include uterine tenderness, fever, and fetal tachycardia if an intraamniotic infection is present. Next, let's talk about how to diagnose PPROM. Diagnosing PPROM involves a combination of clinical evaluation and diagnostic tests. The pooling of fluid in the vaginal vault is a key sign. Nitrazine testing, which identifies the alkaline nature of amniotic fluid, and Ferning patterns on microscopy are commonly used. Ultrasound imaging plays a crucial role in assessing amniotic fluid levels and confirming the diagnosis. It's also vital to monitor for signs of intraamniotic infection and fetal distress through clinical and laboratory evaluations. Moving on, let's explore the management and treatment of PPROM. The management of PPROM depends on the gestational age and the presence of any complications. For pregnancies less than 34 weeks gestation without complications, expectant management is preferred to allow for in utero fetal development. This includes administering prophylactic latency antibiotics, such as ampicillin and azithromycin, to prevent infection and prolong the interval between membrane rupture and delivery. Antenatal corticosteroids like betamethasone are given to promote fetal lung maturity. Continuous fetal surveillance is also essential. If there are signs of intraamniotic infection or fetal or maternal compromise, immediate delivery is indicated, with appropriate infection management using antibiotics and other supportive measures. For pregnancies between 34 and 37 weeks, delivery is generally recommended, along with Group B streptococcal prophylaxis using penicillin G and consideration of corticosteroids based on the clinical scenario. Now let's consider a case study to illustrate these points. A 30-year-old woman at 32 weeks gestation presents with a sudden gush of fluid and subsequent leakage. She has a history of bacterial vaginosis earlier in the pregnancy and reports no contractions or pain. On examination, nitrazine testing is positive for amniotic fluid. Ultrasound confirms reduced amniotic fluid volume, and there are no signs of infection or fetal distress. She is managed expectantly with latency antibiotics and antenatal corticosteroids. Fetal monitoring is initiated and she is closely observed for any signs of infection or labor. At 34 weeks, she develops mild uterine tenderness and a low-grade fever. Given the signs of a possible intra-amniotic infection, the decision is made to proceed with delivery. The patient receives appropriate antibiotics and delivers a healthy baby with minimal complications. In summary, the management of PPROM requires a balanced approach to prolong fetal development while preventing maternal and fetal complications. Early recognition, appropriate use of antibiotics and corticosteroids, and vigilant monitoring are key to successful outcomes. We encourage you to engage with the pre- and post-podcast quizzes and use the Anki flashcards provided to reinforce your understanding of this critical topic. Thank you for joining us on Med Madness. Stay tuned for our next episode and keep advancing your medical knowledge.